welcome to the neuroendocrine tumor masterclass. The masterclass series have been a real success with hundreds of physicians from the UAE and UK attending. And today, again, we're going to talk about the latest clinical practice and scientific updates in neuroendocrine tumors. At Imperial, we're very privileged to have a world-class neuroendocrine tumor multidisciplinary team that convenes at Hammersmith Hospital every week, and endocrinologists, radiologists, surgeons, and oncologists with an interest in neuroendocrine tumors discuss cases to adopt the best approach for the treatment of our patients. And today, the masterclass series is going to have the format of an MDT, but with 4 separate talks. The first 2 focus on diagnosis of NETs, so biochemical diagnosis and radiological diagnosis. And then the latter 2 are on management, so surgical management of NETs and oncological management of NETs. And it's my privilege to welcome our first speaker, Dr. Florian Wernig, who's going to talk about biochemical diagnosis of NETs from an endocrinologist's perspective.
Thank you. Thank you for the introduction. So today I'll be discussing the biochemical diagnosis of neuroendocrine tumors. Focusing on functional and non-functional neuroendocrine tumors, and the role of secretory biomarkers such as chromogranin A or 5-HIAA, and I will talk about carcinoid syndrome. Finally, I'm going to talk about some functional gastroenteropancreatic neuroendocrine tumors, and we'll be presenting some interesting cases from our neuroendocrine tumor clinic. So neuroendocrine tumors can originate from any neuroendocrine cells throughout the body. The majority of them are well differentiated, and well differentiated neuroendocrine tumors often retain their ability to secrete peptides and other molecules. Functional neuroendocrine tumors are defined as those who have the propensity to produce hormones and other vasoactive substances, which can give rise to various clinical syndromes. They can be sporadic or syndromic. And if they're syndromic, they can be part of MEN1, MEN2, or von Hippel-Lindau disease. They are rare, and only 10% of neuroendocrine tumors cause carcinoid syndrome. They are often asymptomatic until they have metastasized and are in advanced stage, and the median age of diagnosis is around 60 years. They are classified and differentiated as low-grade, intermediate-grade, and high-grade tumor, depending on their Ki-67 proliferation index. And the cutoff between low and intermediate grade is 3%. There's a wide range in the intermediate grade from 3 to 20%, and everything more than 20% is classified as a high-grade neuroendocrine tumor or high-grade or actually neuroendocrine carcinoma. So the well-differentiated neuroendocrine tumors usually retain their ability to produce secretory hormones, whereas this ability is often lost in high-grade cancers. If we distinguish between the non-functional and functional neuroendocrine tumors, so the non-functional tumors produce non-hormonal secretory products such as chromogranin A, neuron-specific enolase, pancreatic polypeptide, pancreastatin, or novel circulating biomarkers, the so-called NET test, which is a multi-transcript molecular assay that measures the expression of various genes, about 51 genes associated with neuroendocrine tumor activity, but it's not very widely available. As functional neuroendocrine tumors produce various hormones causing symptoms such as serotonin and 5-HIAA, gastrin, insulin, glucagon, or vasoactive intestinal peptide. There are also some rarer hormones associated with neuroendocrine tumors, such as PTH, PTH-RP, or ACTH. So the general approach is that non-hormonal tumor markers are not recommended as a diagnostic test or even post-treatment surveillance of non-metastatic neuroendocrine tumors. And I'm sure we will hear later in this session that imaging remains central and markers are used together with imaging. The most widely used and commonly used marker in clinical practice remains chromogranin A. It does correlate with disease burden and treatment response, particularly in advanced NETs, neuroendocrine tumors, not so much in localized disease. However, there can be false positives if patients take proton pump inhibitors, there's a response to certain foods or chronic gastritis, or there's falsely elevated results in renal failure. Also, assays are not always standardized. And somatostatin analogs can affect the value of chromogranin A without a correspondence reduction in tumor mass. The other markers I mentioned earlier, neuron-specific annulase, are less sensitive and less specific, but may reflect aggressive disease if elevated, or dedifferentiation of disease. Pancreatic polypeptide has little clinical use, but is sometimes elevated in pancreatic gastrointestinal neuroendocrine tumors. Pancreastatin, not very widely available, derived from chromogranin A. It's not affected by proton pump inhibitors and may actually correlate better with disease progression, but there's limited data. So major guidelines do not recommend routine use of non-hormonal markers for diagnosis, post-treatment surveillance, or monitoring, as I mentioned earlier. And that is because of all the concerns I just alluded to. So poor sensitivity, specificity, influenced by medications. And if they're used for diagnosis, as with other tumor markers, it can create unnecessary anxiety and can lead to inappropriate treatment decisions and treatment changes due to marker fluctuations. So in summary, there's a limited role in modern NET management for chromogranin A and similar markers. And their main role really is together with clinical assessment and imaging and for diagnosis and follow-up. And if they're used, we should use serial measurements, and they should ideally be done with the same assay and interpreted with caution. Now, this is a picture of one of our patients with carcinoid syndrome. And you can see typical features of facial flushing. This is caused by serotonin release and vasoactive peptides. And this patient was referred to our clinic. And this is the original GP referral. And I quite like to show you this because it's a very beautiful description of someone with carcinoid syndrome. So I'll read it out. It's many thanks for seeing this 56-year-old patient who presents with a 3-month history of episodes of quite severe flushing. These are becoming more frequent and are now occurring 4 or 5 times per day. He says that people have commented on him becoming quite red when the attacks occur, and he finds that they leave him feeling fatigued and unwell afterwards. On examination, his pulse is 65 and regular blood pressure is 131/78. Blood tests to date have not shown any obvious cause for the symptoms. I would be very grateful for your opinion, yours faithfully. So this is a very good description of someone with carcinoid syndrome. However, we get many referrals of similar referrals to our clinics, and only a minority of those patients then truly have carcinoid syndrome. So as I alluded to earlier, serotonin is secreted by small bowel neuroendocrine tumors and can cause symptoms such as diarrhea, flushing. This only occurs when it bypasses the liver metabolism. That means if the neuroendocrine tumor has already metastasized to the liver. The preferred analytic metabolite is 5-HIAA, which is less subject to dietary and drug interference and less subject to sampling handling issues. However, it does require dietary restrictions, and it's important to tell our patients to avoid serotonin-rich foods and certain medications. It's most reliable for so-called midgut neuroendocrine tumors, and so those of small bowel origin mainly, and it is sensitive and specific for carcinoid syndrome, but not so much for localized disease, so for metastatic advanced disease. Plasma 5-HIAA is an alternative, but it's not widely available. It has been used, and there are publications when it was used together with 24-hour urine baseline collection for monitoring of disease progression. So the clinical use is for diagnosis of carcinoid syndrome, in particular patients present with diarrhea and flushing, for risk stratification, monitoring patients with metastatic serotonin-producing tumors, and evaluate the etiology of diarrhea in neuroendocrine tumors. So we generally recommend to do a urine collection every 6 to 12 months. So I just want to highlight that unlike non-hormonal markers such as chromogranin A, hormone measurements such as serotonin or 5-HIA are essential for diagnosing and monitoring functioning neuroendocrine tumors that cause clinical syndromes. It's also useful to evaluate the risk for carcinoid heart disease, because they can lead to fibrosing of heart valves, in particular right-sided heart valves. Our patient underwent 5-HIA analysis, 24 urine collection, and had significantly elevated levels, and subsequently underwent the gallium scan. And you can see this is the same patient who at presentation had extensive liver metastases, which were due-to-date avid. The primary tumor was not obvious, but we presumed that it was a small bowel primary neuroendocrine tumor. So this just summarizes what we discussed. It predicts the risk of carcinoid heart disease and also carcinoid crisis during surgery. And that is something else, because there's guidelines that actually would recommend octreotide to prevent carcinoid crisis. And that leads us to management overview, which we can divide into symptom control and tumor burden reduction. So symptom control is mainly achieved with somatostatin analogs such as octreotide, but also it is important to try to reduce the tumor burden with surgery, debulking surgery, liver embolization of liver metastases, or PRRT, peptide receptor radionuclide therapy. There are also serotonin inhibitors like telotrista, the tryptophan hydroxylase inhibitor, which does have some effect with flushing, not so much with diarrhea. And as I briefly mentioned earlier, before an operation or any intervention, we tend to recommend octreotide pre-treatment and an octreotide infusion during surgery. And it's not part of this talk to go into details, but I can just refer to the guidelines published in 2022 on carcinoid syndrome and carcinoid heart disease, where recommendations are being made for octreotide cover for procedures and surgery. Now, other hormones released by pancreatic neuroendocrine tumors are hormones such as gastrin, leading to Zollinger-Ellison syndrome. So gastrin is produced by gastrinoma, which is usually in the duodenum of pancreas. And it's important to remember that 20 or 30% of those tumors are related to MEN1, multiple endocrine neoplasia type 1. That means that all patients diagnosed with Zollinger-Ellison syndrome or gastrinoma need to have genetic testing. They usually present with symptoms, peptic ulcers, diarrhea, reflux disease. And if the gastrin level at baseline is more than 1,000 picograms per milliliter, together with a low gastric pH, this would be diagnostic of Zollinger-Ellison syndrome. Ideally, the proton pump inhibitor therapy should be discontinued, but this is not always possible because some patients may not tolerate that. But it does give rise to falsely elevated gastrin levels. Historically, we used to do secretin stimulation testing if the gastrin was less than 1,000 picograms per milliliter. And I will have a link later to where you can see the test protocols in more detail. We also have to bear in mind that, for instance, type 1 gastric neuroendocrine tumors, so those related to atrophic gastritis, vitamin B12 deficiency, pernicious anemia, leading to achlorhydria, can also give rise to elevated gastrin levels. and would give a false positive result. So other hormones being related by pancreatic tumors are insulin, and I will talk more about insulinomas in a minute, as well as glucagon and glucagonomas. Glucagonomas are usually large pancreatic tumors. They often have already metastasized the diagnosis and present with symptoms such as diabetes, weight loss, glossitis, or necrolytic migratory erythema. And the diagnosis is usually made by elevated fasting glucose, but symptoms may persist even with modest glucagon levels. So this is a picture of the skin changes that can occur with glucagonomas. Lipomas, VIP-producing neuroendocrine tumors, are rare pancreatic tumors and occur mostly in the tail of the pancreas. They cause severe watery diarrhea, hyperkalemia, and achlorhydria, so the so-called WDHA syndrome, watery diarrhea, hyperkalemia, achlorhydria syndrome. Diagnosis made by elevated VIP levels plus the clinical features of really profound watery diarrhea. Now back to insulinomas, because it's possibly something we do see slightly more common than the other tumors. So insulinomas are still very rare pancreatic neuroendocrine tumors that secrete insulin inappropriately, leading to recurrent hypoglycemia. They were first recognized in 1920, and following observation of hypoglycemia in non-diabetic patients. And usually the curative treatment is surgical excision of the tumor. The incidence is 0.1 to 0.4 cases per 100,000 person years. And they commonly occur around the age of 40 to 56, but can occur at any age. There seems to be a slight female predominance in some series, and 5 to 8% of cases, or some cases, are associated with MEN1, and in MEN1, it's about 5 to 8% of cases of pancreatic tumors being insulinomas. If they're syndromic, then patients often present with multiple tumors, not just single tumors. The pathophysiology is not entirely clear. They secrete insulin despite hypoglycemia, arise from pancreatic cells, not always the classic islet beta cell origin, and they may involve altered messenger RNA translation enhancing insulin production. The clinical features are fasting hypoglycemia presenting with neuroglycopenic symptoms, such as confusion, visual changes, altered consciousness, but also some autonomic symptoms such as palpitations, tremor, and sweating. Patients often develop hyperphagia, and weight gain is an important feature which occurs in about 50% of patients. As far as common symptoms are concerned, about 73% of patients present with fasting symptoms. Some have mixed fasting and postprandial symptoms, and there's a minority of patients who have pure postprandial symptoms. And it's sometimes difficult to distinguish between reactive hypoglycemia and insulinomas. Diagnosis is often delayed because it's a very rare condition, and it can be months or even years until patients are diagnosed. They're often misdiagnosed as epilepsy or psychiatric illness. The diagnosis is made clinically by the Whipple's triad, which means documented hypoglycemia, symptoms of hypoglycemia, documented hypoglycemia, and relief of hypoglycemia by food. Then the gold standard biochemical confirmation is a 72-hour supervised fasting test. And that needs to be conducted in a monitored setting with glucose and regular ketone checks. Hypoglycemia is defined as a glucose level of less than 2.2 milligrams. When this occurs, then blood is being taken for insulin C-peptide, as well as a sulfonylurea screen and ketones. And it is important to wait until the laboratory actually confirms that the blood glucose was indeed less than 2.2 millimoles per liter. we can make a diagnosis of an insulinoma if the insulin levels are more than 6 millunits per liter, the C-peptide levels more than 300 picomoles per liter, a negative sulfonylurea screen, and suppressed ketones, as insulin suppresses ketosis. Now, there is, of course, a gray zone where the insulin levels are between 3 and 6 millunits per liter. And this may have to be interpreted in the clinical context and sometimes needs more testing. So here are some tips for the interpretation. So high insulin, high C-peptide in the context of hypoglycemia and low ketones are in keeping with an insulinoma, so endogenous hyperinsulinism. High insulin, low C-peptide are indicative of exogenous insulin use, something we have to rule out. So we would only potentially pick up insulin use, but not sulfonylurea use, because this would give rise to the first picture with high insulin and high C-peptide levels. If there's low insulin, low C-peptide in the context of hyperglycemia, it can be an entirely normal response, and one would expect also the blood ketones to be elevated. 66% of insulinomas are diagnosed within the first 24 hours of a 72-hour fast, 95% within the first 48 hours. And if no hypoglycemia after 72 hours occurs, and after 15 minutes of exercise, that means walking around the ward or up and down the stairs, then an insulinoma is highly unlikely. Now, that leads me to our first clinical case, which is a 70-year-old woman presented to our clinic with a 20-year history of blackouts and hypoglycemia. So she was initially seen in a different institution where a 72-hour fast was carried out, and she had a significant hypoglycemia, but appropriately suppressed insulin and C-peptide levels. At that time, blood ketone levels were not tested. So it was labeled as normal and not as an endogenous insulin producing source. Her symptoms persisted and became actually more severe, and she had several blackouts. She lived alone and was found unconscious the following morning. And so we repeated her tests, and once again, she achieved hypoglycemia after 24 hours with an nadir blood glucose of 1.9 millimoles per liter. Insulin C-peptide levels once again appropriately suppressed, but her ketones were negative, so they were undetectable. Sulfonylurea screen was also negative. So she went on to have imaging, and the preferred imaging modality, as we may hear later, is a gallium-2 PET-CT, which showed several 3 totated avid pancreatic lesions, which you can see here. So this is once again the biochemistry. So after 24 hours, the nadir blood glucose was 1.9 millimoles per liter, negative plasma ketones, and fully suppressed insulin and C-peptide levels. So we looked for other causes that could potentially lead to a similar picture, such as excess IGF-2 production. And her IGF-2 to IGF-1 ratio was not elevated, so we could rule that out biochemically. We also then checked her proinsulin level, although one would expect her insulin level also to be elevated if proinsulin was elevated. However, surprisingly, the proinsulin level was significantly elevated with a fully suppressed insulin. So this was unusual, and we therefore wanted to analyze this further and carried out whole exome sequencing, which did not reveal any mutations in the BCSK1 or BCSK2 genes, which are usually involved in glucose homeostasis. But what we found was a truncating somatic mutation in one of the VATP proton pump genes, which is critical for acidifying insulin granules. There were also several upstream regulatory gene mutations possibly affecting the PCSK expression. So whilst we cannot 100% say that this mutation we found was pathogenic, it could provide a possible explanation why this patient actually had elevated pro-insulin levels with fully suppressed insulin. It just highlights the importance that to measure other hormones such as proinsulin or IGF-2 if insulin levels are suppressed, and otherwise these patients would have been misdiagnosed. So this lady underwent surgery, and all 3 lesions were excised, and it has now been several years, and she has remained in full remission and fully asymptomatic. I just want to briefly present another case, which is a 49-year-old male with presented with palpitations. So he was found to have recurrent hyperphosphatemia with phosphate levels as low as 0.18 millimoles per liter. He did not have any musculoskeletal symptoms, and the past medical history included hypertension, hypothyroidism, and obstructive sleep apnea. Interestingly, he had a family history of metastatic small bowel neuroendocrine tumors, and his mother passed away a year earlier from a metastatic small bowel NET. His diagnostic workup included normal calcium, PTH, vitamin D levels, normal renal function, but a high urinary phosphate of 81.7 millimoles per day. We measured his FGF23 level, which was also elevated at 135, the normal reference range being less than 100 units per milliliter. And he was also found to have low TMP GFR, which is the tubular maximum for phosphate reabsorption per glomerular filtration rate, a marker of renal phosphate handling. So he went on to have a gallium-38 PET-CT, which is the preferred imaging modality to look for a tumor causing tumor-associated osteomalacias, an FGF23 producing tumor. And surprisingly, they showed a 50 millimeter somatostatin receptor positive mesenteric node. We didn't find a primary tumor on CT or capsule endoscopy. And what you can see here is this high, very intense data-date avid mesenteric node as, in the proximity of the small bowel. His initial treatment was intravenous and oral phosphate and alpha-calcitrol, and he underwent surgery together with a small bowel wedge resection, which actually identified a small bowel primary and the mesenteric node. Interestingly, his phosphate normalized by day 3 postoperatively, and he did not require any supplementations. He has not required any supplementation since. Histology showed a grade 1 small bowel neuroendocrine tumor, and at 3-month follow-up, he hasn't had any recurrence of his tumor on a repeat PET-CT, and his urinary phosphate and FGF23 fully normalized. Here you can see the urinary phosphate excretion, which fully normalized after his surgery, and the FGF23 level went back to normal, being 72. And that was his preoperative gallium scan and the postoperative gallium scan, which is essentially negative and did not show any tumor recurrence. So tumor-induced osteomalacia, I may not have time to go through that. It's very rare and usually not associated with neuroendocrine tumors. There's only a handful of case reports in the literature, and this is a very unusual case. So in conclusion, neuroendocrine tumors are a very heterogeneous group with variable hormone secretion and clinical syndromes. The biochemical diagnosis relies on understanding of the functional status of the tumor and their specific hormonal profiles, as we discussed. 5-HIA is the preferred test for carcinoid syndrome, but it requires careful interpretation and patient preparation. And chromogranin A and other non-hormonal markers have limited standalone diagnostic value. So it's always important to interpret biochemical results in the clinical and imaging context. Somatostatin analogs are central to managing hormone-related symptoms and tumor progression. And remember to assess and monitor for carcinoid heart disease and serotonin-secreting tumors. This is a link to the Endocrine Bible, where you can find all the testing protocols, for instance, the testing protocol for the 72-hour supervised fast, water tests I mentioned in my talk. Many thanks.
Thank you very much, Dr. Wernig, for a very clear, concise, and comprehensive overview of the biochemical diagnosis of NETs. Now, I'm conscious that you are actually in the middle of your clinic at Hammersmith Hospital, and in the interest of time, I'm going to move on to our next speaker. Thank you again, Florian. Now, having made a biochemical diagnosis, we then turn to our radiology consultant, and I am delighted to welcome Dr. Mitesh Naik, who is our consultant radiologist in our MDT, so nuclear medicine specialist, and he is going to talk about the radiological diagnosis of neuroendocrine tumors. Dr. Naik, over to you.
Perfect. Thank you for the introduction. Hopefully you can see my screen. I will just revert to full screen. Perfect. So yes, my name is Mitesh, one of the radiology consultants working at Imperial alongside my esteemed colleagues. During this talk, I wanted to touch on several areas. The first of which is defining the role of imaging in the diagnosis of neuroendocrine tumors, going through the choice of investigations that we have in our sort of plethora of ammo, including the pros and cons, and also emphasizing multimodality imaging and why it's so relevant in all cases. I'll touch briefly upon PRRT and the role of imaging in work up to that, and also, if we have time, discuss response assessment. So neuroendocrine tumors, obviously we've heard a lot about this already. I will be focusing on GEP nets and lung nets predominantly, so I won't be touching on other primary sites described below, nor will I be discussing pheochromocytoma or paraganglioma. So in terms of diagnostic investigations, of course, we have our biological workup, including histology, if a site is appropriate and has been sampled, in addition to biomarkers with strengths and weaknesses inherently as well, as described by Dr. Wernig. We have anatomical tests, including ultrasound, CT, and MRI, and then really molecular imaging has transformed the way in which we diagnose and we stage neuroendocrine tumors. And it's also enabled us to learn a lot more about the biological behavior of these tumors. So why do we image? Well, so a histological diagnosis may have been made already. We want to try and localize that disease, determine how far it's extended, stage the disease appropriately, identify whether there's nodal spread, and then subsequently metastatic spread also. This will inevitably have implications on treatment, whether or not the patient is suitable for local regional therapies, surgical treatment, which could, with curative intent potentially, or whether systemic treatment needs to be considered early on. Furthermore, it's appropriate to assess whether the patient will be appropriate for PRRT, and subsequently assess response to treatments once instigated. Disease heterogeneity is a concept that you're all familiar with, I'm sure, but neuroendocrine tumors really vary in terms of their biological behavior. And what this essentially means is on imaging, they don't all follow the same signature across both structural and functional imaging. And therefore, using a combination of these modalities is really quite fundamental to help prognosticate. And in addition, in imaging, more often than not, especially in the low-grade neuroendocrine tumors, which are non-functioning, these tumors may be detected incidentally in patients that are scanned for other reasons, pertinent because of their insidious onset. So I've touched on this already. Why is accurate staging important? We want to determine whether or not the patient is suitable for curative treatments, for metastasis-directed treatments, which are expanding quite rapidly. So, for example, liver-directed treatments, embolization, chemoembolization and radioembolization, and also systemic treatments. So I'll now go in turn to describe the strengths and weaknesses of each of the modalities I've got displayed on this slide. We'll start off with ultrasound. So ultrasound, we know, is a widely available test, and it doesn't require any ionizing radiation, which is of course helpful. It is extremely operator dependent, and limited depth penetration really precludes its use in the majority of neuroendocrine tumors, depending on location. Some situations in which it may be helpful are in evaluation of pancreatic neuroendocrine tumors in particular, because the pancreas' anterior structure can be visualized quite well. Contrast enhanced ultrasound, depending on center availability, can be helpful to elucidate the vascular nature of these tumors especially. But fundamentally, ultrasound is used endoscopically to make a diagnosis of the foregut and of the pancreas to try and sample tumors, enabling FNA. And furthermore, biopsy of liver lesions is also feasible. So in terms of appearances, it's unlikely that you would see this in clinical practice. Most of the time, these are recognized incidentally on a general ultrasound list as an incidental finding, but they typically appear as hypoechoic, so dark lesions, which are very vascular on Doppler assessment in both the pancreas and the liver. Most metastatic lesions within the liver are hypoechoic, so there is a differential diagnosis here, and biopsy is required. Occasionally, they can have a target appearance where they can alternate in terms of their brightness and darkness, so a bright center surrounded by a darker periphery. So there are a couple of examples on the next few slides. So this is an example of a pancreatic neuroendocrine tumor in the center of the screen, so a round, uniformly hypoechoic lesion. And on the next slide, where the star is demonstrated, on the left-hand side, this displays contrast enhanced ultrasound, which you may not be familiar with, but microbubbles are injected into the patient, and dynamically the patient is scanned. The yellow that you can see on the screen is a depiction of blood flow, and so you can see that the lesion entirely fills in, and this is on an early set of images. And here we can see a classical example of a liver lesion, which is suspicious. It's irregular, it's hypoechoic, so dark compared to the surrounding liver parenchyma. Okay, so now moving on to cross-sectional imaging. So CT is essentially fundamental for workup in patients initially diagnosed with neuroendocrine tumors. It's optimal for anatomical detail, including vascular anatomy, which is really important when thinking about surgical management, especially with the relationship with the proximal mesenteric vessels, for example, if there's a scenario of a mesenteric mass to determine resectability. It's quick and of course it's readily available. It does expose patients to radiation. Its sensitivity does vary depending on the phase of the contrast, and I'll come to that in a second. And there can be contraindications, for example, in severe renal impairment. However, even that is slightly debatable now, given the contrast-induced nephropathy, and the impact of that is increasingly discussed in recent years. So in terms of the appearances, characteristically, so you'll see a theme as I go through each modality. These lesions are typically hypervascular, especially in the low to intermediate grade tumors. So they show really quite rapid and pronounced arterial phase enhancement. They can calcify irrespective of location. And the characteristic appearance of a midgut net, which you may have all seen before, is that of a mesenteric mass, particularly with spiculation, apologies for the typo, and desmoplastic reaction, and I'll show you an example of that in a second, where there's indrawing of the surrounding structures. So in terms of use of CT, essentially all neuroendocrine tumors really, to get the anatomical detail that you require, are being worked up for surgery. And in addition to that, optimization of CT for assessment of bowel can be performed. So doing CT enterography, or even potentially CT colonoscopy using a neutral or negative contrast agent to highlight luminal lesions. So just to speak a little bit about CT contrast and why it's so relevant. So those unfamiliar, the difference between an arterial and a portal venous phase is as such. So the top right image describes where the contrast is injected on the left-hand side. An arterial phase, ideally a late arterial phase for neuroendocrine tumors, is performed at about 30 to 35 seconds after contrast administration, followed by a late portal venous phase at around 70 to 75 seconds. And you can see the images below. show what we're that we've achieved a good arterial phase quite clearly. So you look at the central aorta, it's really well enhancing, and you can see here the pancreas is really nicely highlighted as well because it's quite a vascular organ. The reason why we do the portal venous phase as well is because at that stage, the majority of the blood pool, of contrast bolus rather, is within the portal venous axis, and this is the best opportunity to evaluate the remaining viscera for sites of metastatic disease predominantly. So the next few slides will highlight why dual phase imaging is fundamental. So if you're ever surveying these patients or even trying to make a diagnosis of neuroendocrine tumors, it's essentially impossible without arterial phase imaging because you will completely miss the lesions. So here we have an example of a gastric neuroendocrine tumor with some of the characteristic features I just mentioned. So the arrow demonstrates there's a big lesion arising from the gastric greater curve of the body. The portal venous phase is demonstrated on the right, and you can see the calcifications, but it's less sort of confidently delineated. On the left-hand side, you can see it's really quite well enhancing here. In the same patient, the arterial phase again is on the left. You can see an arterially enhancing liver metastasis. So the metastases can also enhance in the same phase of contrast, which are completely missed on the portal venous phase on the right-hand side. Here's an example of the mesenteric mass with the desmoplastic reaction. So you can see spiculation of the margins, you can see central calcification, you can see sort of pulling in of these blood vessels surrounding it. So it has this sort of stellate appearance adjacently. And you can also see some enhancement of an adjacent small bowel loop. So for us as radiologists, delineation of the mesenteric mass can be quite helpful because you essentially know that the tumor is going to be loco-regional to that. And so we really have to scrutinize the small bowel loops directly adjacent to try and see if there's a focus of enhancement. And this is the PET that just highlights that far more clearly. This is a dotatate. So this is what I was talking about in terms of CT enterography. This actually was an unprepared study, but you can see there is better delineation of this arterially enhancing lesion within the distal ileum as a result of low density fluid in the surrounding ileum as well as the cecum. And it just highlights that lesion far more clearly than it would, for example, if you compare to a small bowel loop on the left-hand side, which is non-distended. There may well be a tumor in here and we'd never be able to identify it. So there are limitations to every test, and that is one of them in terms of delineation of sort of luminal lesions on an unprepared study. And this is just to show that there is a differential diagnosis. So although imaging is really helpful once a diagnosis is made histologically, it's not a diagnostic test per se, unless we have somatostatin receptor imaging. So on the left-hand side, we have a rounded mesenteric mass. On the right-hand side, we also have a rounded mesenteric mass. One of them ended up being a gastrointestinal stromal tumor. You can see it's slightly contiguous with an exphytic component extending to the adjacent small bowel loop. That's not diagnostic, but it's a described feature. And on the right-hand side, this ended up being a neuroendocrine tumor. And this is the primary lesion of the right-side neuroendocrine tumor in the distal ileum. So this slide just describes several other differential diagnoses for mesenteric masses. So even when we find a mesenteric mass, if it has those other features that I described on the previous slide of spiculated margins, central calcification, and ingrowing in particular of the small bowel loops, that's very characteristic. However, a mesenteric mass in isolation is not specific for a neuroendocrine tumor. Here we have an example of relatively arterialized, once again, contrast CT of the thorax. And here you can see a left perihilar nodule, which is quite well enhancing, which is causing bronchocele to form within the anterior left upper lobe. So you can see that it's obstructed that airway, causing fluid to accumulate within it. In terms of higher grade neuroendocrine tumors, imaging can be helpful to assess disease burden. However, there are no specific imaging features. So here we have a cecal lesion on the right-hand side within the abdomen with some extramural extension. On this scan, we cannot make distinction over whether this is a primary lower GI adenocarcinoma, for example, or a neuroendocrine tumor. The appearances can really overlap when neuroendocrine tumors are high grade, and their features on imaging are the same as any other tumor, and histology is needed. Here we have some examples of pancreatic neuroendocrine tumors. So on the left, again, that characteristic hyperenhancement. Just another thing to mention is one of the other pitfalls that we often see on imaging. Neuroendocrine tumors can be cystic, and this is really important because cystic lesions of the pancreas are incredibly common. If there's any enhancing component related to a pancreatic cyst or any hesitation whatsoever, an EUS should really be performed, because although this nodule in particular does show some quite typical enhancement along its lateral aspect, this isn't always the case. And not unusually do we see a cyst being aspirated only to reveal a neuroendocrine tumor. So again, this is sort of to hammer home the point that imaging is not 100% absolute. There is a differential even when seeing vascular lesions within the pancreas. So on the left-hand side, this was actually a renal cancer metastasis, which is why history is so important. Renal cell cancers, especially alongside other tumor types like melanoma and germ cell tumors, characteristically cause hypervascular metastases. So in a similar way, they can cause arterially enhancing liver lesions and arterially enhancing pancreatic lesions. And on the right-hand side, splenules are essentially little islands of spleen that are separate to the splenic parenchyma. They can be either adjacent to the pancreatic tail, or they can even be within the pancreatic tail. And that really poses a huge diagnostic dilemma on imaging. Again, EUS can be extremely helpful if accessible. But, you know, again, it depends on whether that's feasible. Oh, sorry. It depends on whether that's feasible. If it's dorsal to the pancreatic tail, it may not always be amenable to EUS sampling. Okay, so MRI is really helpful for liver metastases detection in particular. I'll show you a couple of examples as to why in a second. It's really helpful for soft tissue characterization and considered slightly better than CT, especially for pancreatic neuroendocrine tumors, according to literature. In clinical practice, this can be debatable because MRI is prone to artifact, and particularly in small lesion sizes, there are situations where lesions are detected far less well, depending on local scanners availability and depending on their parameters. The lack of radiation is, of course, a positive as well. However, there are contraindications in terms of patient factors. For example, claustrophobia is not to be underestimated, metallic devices, and also allergy to gadolinium. So in terms of their appearances on MRI, they're typically T2 hyperintense. So T2 is a fluid sensitive sequence, and they show up as bright on those images. They're again hypervascular on the arterial phase, and they can also show diffusion restriction. And I'll show you an example of that as well. But what that indicates is increased cellularity within a lesion. It's not specific for a neuroendocrine tumor, but it essentially means that the lesion is of concern. So it's likely to be neoplastic, or it could be infective as well. In terms of its uses, fundamentally, it's mostly used for pancreatic neuroendocrine tumors and also for as an adjunct to other diagnostic tests for staging and restaging to assess the liver specifically. MRI enterography can occasionally be used, but more often than not, this is when neuroendocrine tumors are picked up as an incidental finding on patients with non-specific lower GI symptoms or upper GI symptoms. It can finally also be used for troubleshooting of lesions identified on other tests. There are non-specific findings that can be seen on somatostatin receptor imaging, in particular in the bones and the brain. So here's an example of a pancreatic tumor on MRI. On the left-hand side, I've got a T1 weighted fat saturated sequence where it's of low signal. And then on the top right, contrast has been administered. You can see the kidneys are highlighted and very bright, and the pancreas, the lesion within the pancreas also uniformly enhances. The bottom image shows a T2 weighted sequence, which is slightly noisy, but you can see it's got that bright signal that I mentioned, you can compare this to the gallbladder or the adjacent fat, and you can see that they're similar in terms of their intensity. And here's an example of a cystic pancreatic lesion once again. So cystic NETs, as I showed you an example on CT, this is essentially the same scenario on MRI. So uniformly hypo-intense on T1 weighted imaging, akin to the right renal cyst. There probably is some soft tissue which is enhancing along its medial aspect, but quite difficult to detect. I'm sorry that my slides keep skipping. Oops. Okay, so here's an example of why MRI is sort of demonstrating the improved sensitivity of MRI compared to CT. So on the top left image, I do have arterial phase imaging, but you can only see a couple. I'm sorry, I think my computer is doing something a little bit strange. Sorry about this. Okay, I think we're back. Sorry about that. So on the top left, you can see a couple of enhancing lesions within the liver. However, on the bottom, you can see this is the delayed phase of an MRI where the contrast is actually washed out of all of these liver metastases. So everything you can see within the liver, which is dark, is a metastatic focus, highly significantly underestimated on the CT, even with arterial phase. On the bottom right, we have diffusion weighted imaging. So this is a DWI. There's normally a corresponding ADC, but on the DWI, these appear as hyperintense, so bright foci, and this is one of the best sequences to evaluate for liver metastases. We've already described some of the pancreatic neuroendocrine tumor mimics, but just to mention, there are several more as well. Okay, so now on to functional imaging. So somatostatin receptor imaging is really fundamental now in terms of diagnosis and follow-up in these patients. So the radiopharmaceuticals that are administered have a really high affinity for somatostatin receptors 2 and 5 in particular, and PET and SPECT tracers have both been used. So Octreoscan, which was historically used, and that's a SPECT pharmaceutical, i.e. releases gamma emissions for detection on a gamma camera and then superseded by a three-dimensional SPECT, has been superseded once again by PET. And that's predominantly using gamma labeled pharmaceuticals that are labeled to dotapeptides. So that includes dotatate, dotaTOC, and dotaNOT. These all have slightly variable affinities to the 5 different somatostatin receptors, but all are considered equally effective clinically. The benefits of PET include higher spatial resolution and lesion detectability, faster image acquisition. So Octreoscan used to be a 2-day protocol, whereas with gallium dotatate, the pharmaceutical is injected, the patient is scanned 45 minutes later, and that's it. There are also theranostic applications in relation to PRRT. So thinking about the theranostic pair of gallium dotatate and lutetium dotatate, which is the central focus of PRRT. It also offers a significantly lower radiation dose than indium, which is for higher energy, and it's commercially available. So here's an image just to show you the improved sensitivity of gallium dotatate on the right-hand side compared to Octreoscan on the left. On the left, you really can't make out any liver metastases, and in addition, there's also a mesenteric lymph node within the upper abdomen, which is highlighted with the second arrow on the right-hand side. So far superior in terms of lesion detection. In terms of when somatostatin receptor imaging is used, so it can detect sites that are occult on other modalities, particularly in the bone, and particularly thinking about normal sized lymph nodes on CT, which would never necessarily be called abnormal. They can very frequently be intensely avid on somatostatin receptor imaging, therefore confirmatory of disease involvement. It can predict response to octreotide therapy and subsequently PRRT. And it's not contraindicated in renal impairment, which is helpful in several of these patients. Some of the challenges include high background liver uptake. So actually, there's although the example I showed you highlighted liver metastases very nicely, this isn't always the case. So in smaller liver lesions, it can be insensitive and actually underestimate disease there, which is why MRI is frequently used as an adjunct when performing data-tape PET. The spatial resolution does limit assessment, not just in the liver, but also elsewhere. However, PET-CT has actually improved this compared to scintigraphy and SPECT-CT prior. And occasionally there can be false positives and false negatives, which is why they need to be read in expert hands. In terms of uses, fundamentally they're used according to ENET's criteria for grade 1 and grade 2 NETs. They're principal uses of staging at baseline once histology has been obtained, apart from in gastric or rectal NETs less than 1 centimeter, which don't necessarily require any follow-up imaging if they're cured. After curative surgery, where there is the risk of residual or metastatic disease, even if there's no baseline. So on occasion, the patient, for example, could have a right hemicolectomy for other reasons. An appendiceal NET is identified incidentally in a patient that's presented with appendicitis. And subsequent to that, 3 months later, somatostatin receptor imaging may be performed if there was concern histologically over residual disease. In addition, if there's concern over progression and conventional imaging is stable, it will be important to use this as part of the diagnostic workup going forward. And finally, for patient selection for PRRT. In terms of false positives, there can be many false positives on somatostatin receptor imaging. So uncinate process shows uptake physiologically. Splenules can. So again, there can be overlap, just as we saw with MRI. Any bone lesions that show osteoblastic activity, such as hemangiomas and fibrous dysplasia, meningiomas and inflammation. You can also get false negatives from insulinomas in particular, and medullary thyroid carcinomas, and also in high-grade neuroendocrine tumors. So here's an example of a patient that was upstaged with data-date. So on the left-hand side was the index presentation scan showing liver metastases. On the right, you can see one of the liver deposits has increased in size, but the patient was being considered for local regional treatment options. However, you can also see on the bottom right that there is a new tracer avid lesion within the T5 vertebra, which of course altered the patient's management, and therefore they were considered for systemic options instead. Here is an example of a patient who had an MRI scan. I've got one of the images on the bottom left because of concern over hormonal dysfunction. No neuroendocrine tumors were identified. A data-tape PET was subsequently performed as part of workup where a pancreatic NET was seen. So this just emphasizes that every modality is sensitive and specific to an extent, but there's no absolute perfect test. Here's a patient who had 5 CT scans for persistent diarrhea. You can see on the right-hand side, there's real prominence of the rugal folds, which is abnormal in this patient that's got a well-distended stomach. However, nothing was identified in the upper GI tract. In retrospect, there was possibly a nodule along the medial aspect of the proximal duodenum. However, this was in context of the rugal fold pattern extending to that area and probable inflammatory reaction relating to the duodenum. On the right, you can see a data-tape PET, and there's very intense uptake, increase higher than that of liver parenchyma, and this was in keeping with a gastronema. Here we can see a lesion within the medial left lower lobe, which was bronchocentric, causing medial left lower lobe collapse. This was worked up as a conventional lung cancer initially, because although it was enhancing, there's a differential here. The patient underwent an FDG PET. It was entirely negative. A bronchoscopy to sample was attempted. However, no tissue was obtained. And then the data-tape was performed, showing intense uptake. And this ended up being a grade 1 NET. So FDG PET is used as an adjunct. This is a glucose analog, and tracer uptake corresponds to metabolic activity, tumor aggressiveness, and Ki67. So it's really helpful for improving detection of disease with those factors, if there are any concerning features on histology, and also assess the sampling targets in discordant sites of disease. It also has a potential role for prognostication, and again is not contraindicated in renal impairment. It shouldn't be used in low to intermediate grade NETs, and again there are limitations in terms of false positives relating to infection, inflammation, and other malignancies causing FDG uptake. So in terms of where we should be using these, this is for grade 3 NETs or poorly differentiated neuroendocrine cancers, staging before surgery or adjuvant chemo and then subsequent follow-up, or in grade 1 to 2 NETs where conventional imaging is suspicious and there's potentially discordance in terms of some sites showing uptake, other sites showing less uptake. Those other sites, you should always be suspicious that they may be inactive disease or disease which has become necrotic. Alternatively, it could represent dedifferentiated disease, particularly if it's rapidly progressing paradoxically compared to other sites. In addition, when selecting patients for PRRT, especially when they're at the higher end of the grading spectrum, it's important to make sure there's no significant discordance, because we should not be treating patients with PRRT where there is a high burden of somatostatin receptor negative disease. The NET-PET score has been devised and described in literature, where a combination of somatostatin receptor imaging and FDG PET can deliver a 5-point scoring system, and this correlates to overall survival. So survival is worst when disease is considerably FDG positive and somatostatin receptor negative. The Krenning score was actually previously applied for octreotide SPECT imaging, and this is reviewing somatostatin receptor on somatostatin receptor imaging, comparing the uptake of your tumor to background liver, and patients who show tracer uptake greater than background liver are considered better candidates for PRRT. Here is just an example of discordant disease. So this is a patient who had a PET and a dotatate PET, so an FDG PET and a dotatate PET at a similar time frame. They had quite markedly progressing liver disease, and you can see here that there's discordant disease, especially in the liver, where the left lobe is infiltrated by FDG avid disease, which is relatively photopenic on the dotatate PET, and it also shows multiple additional extrahepatic sites of disease, namely within the mesentery, in the cervical spine, and actually at the right breast as well. This is a patient with a neuroendocrine carcinoma that was histologically confirmed following an endoscopy for lower GI symptoms. You can see there's thickening of the rectum on the top left image. There are a couple of small suspicious lesions within the liver, and with the benefit of a retrospectoscope, some very tiny nodules within the lungs, but these were described as equivocal or indeterminate on CT imaging. In the same patient, you can see that the liver disease burden in this grade 3 NET was heavily underestimated in the liver. These very tiny lung nodules actually did show uptake, and given the limitations of spatial resolution, we should always be concerned, even if there's faint uptake in a small nodule. And it also shows that disease had spread beyond the mesorectum locally. Just getting to the end, apologies, I know we're short of time. So PRRT capitalizes on the theranostic pair of gallium and lutetium, which are both labeled to dotatate. Lutetium is a high energy beta emitter, and this should be used in patients who have progressed with grade 1 to 2 NETs on lanreotide, who have confirmed trace avid disease on PET or preceded SPECT imaging. So here I have an example of a patient who had widespread disease, metastatic, progressed on lanreotide. 4 cycles of lutathera were given, and there's a favorable partial response with reduction in extent and uptake of both hepatic and extrahepatic sites of disease on the right. Finally, on response assessment, in terms of the use of imaging and response assessment, it's highly variable. It depends on multiple factors: availability, prognosis, and histological high-risk features if surgery has already been performed. Is there perineural invasion, lymphovascular invasion, and also is there evidence of incomplete resection? And this is why an MDT discussion is essential. In terms of ENETs and the recommendations, they're highlighted here. But it's just to say that there's a lot of variability, and actually dotatate PET imaging isn't always mandated first line. So in the majority of these patients, dual phase CT imaging, provided that disease sites are recognized, is sufficient. If there's clinical concern over progression subsequent to that, that is when dotatate PET imaging is appropriate. For grade 3s, obviously, that would be an FDG, depending on what the baseline imaging had shown. Follow-up imaging is not required for completely resected appendiceal and rectal grade 1 nets less than a centimetre. Rectal nets can undergo endoscopy once following curative resection, and if that's normal, they don't need any further follow-up. For the purposes of brevity, I'll go over this, overlook this slide, and I will summarize just by saying imaging is central to NET diagnosis, grading, and treatment. There are lots of modalities available, and no test is perfect. It's important to bear this in mind, and hopefully what I wanted to emphasize is that there is always a differential diagnosis in these patients, and it's really fundamental to try and get tissue where possible. Somatostatin receptor imaging is of course helpful, but there are also limitations in terms of false positives here as well. FDG is the gold standard for high-grade NET initial staging and restaging, and MRI should be used as an adjunct for liver metastases detection. So I'd like to thank everyone from the neuroendocrine MDT, two of my colleagues, Dr. Khan and Dr. Al Safi, and also Professor Sam for inviting me to speak.
Thank you very much for a very thorough and clear overview of the radiological diagnosis of NETs. Absolutely brilliant. Mitesh, thank you so much. In the interest of time, I think we'll move to the next talk, which will be delivered by Mr. Mikael Sodergren. I'm delighted to introduce him. Mr. Sodergren is consultant hepatobiliary and pancreatic surgeon at Imperial and a clinical senior lecturer. And having heard the story of biochemical and radiological diagnoses from the previous two speakers, we now move on to surgical management of NETs. Mikael, over to you.
Apologies. Thank you very much. And thank you very much for the invitation to speak today. As mentioned, I'm going to speak about the surgical management of neuroendocrine tumors. And let me just get this. That's it. So what I'm going to speak about is really the role of surgery in small intestinal and pancreatic neuroendocrine tumors. I'm going to touch on some of the guidelines, and the guidelines that we followed in Imperial are the ENET guidelines. So I'm going to touch on some of those and some of the recent research relating to some controversial topics, particularly debulking surgery and debulking surgery of liver metastasis, and non-functioning pancreatic neuroendocrine tumors that are less than 2 centimeters in size. So I'm going to start off with this. So preoperative assessment is, as with any surgical pathology, critical and very much so in neuroendocrine tumors. For small intestine neuroendocrine tumors, about 20% of them are functioning, and it's obviously very important to determine this during the preoperative assessment. Patients routinely have gut hormones, 24-hour urinary 5-HAA, and also imaging. The thing to be aware of, both preoperatively in terms of planning your surgery as well as intraoperatively, is that small intestinal neuroendocrine tumors are very, very common to be present in multiple primary sites. So up to 30%, there's more than one primary. And it is, I've seen many, many patients where we've only seen one primary site on preoperative imaging, and intraoperatively there have been multiple. I've operated on one patient who had 4 primary sites, who needed to have 4 small bowel resections. For pancreatic neuroendocrine tumors, the cross-sectional imaging is often the first investigation that we get. We use gallium dotatate PET scans for staging of pretty much all neuroendocrine tumors, as you heard in the previous presentation. And for pancreatic neuroendocrine tumors, the way that we get further radiological clarity in terms of anatomy for resectability, relationship with major vasculature, and also for histological diagnosis is through endoscopic ultrasound. The resectability of the tumors is clearly important to determine preoperatively. For small bowel neuroendocrine tumors, really the factor that precludes, most often precludes the ability for a surgical resection with clear margins are the mesenteric deposits at the root of the mesentery. And so really the way that we visualize those is through conventional CT cross-sectional imaging with arterial and portal venous phases, so we can clearly define the course of the superior mesenteric artery and the superior mesenteric vein down in the mesentery. Here you can see a couple of examples of gallium delta PET scans where you have activity inside the bowel and inside the liver. For resectability of pancreatic neuroendocrine tumors, the endoscopic local resectability, the endoscopic ultrasound is, as I mentioned, what guides us in terms of the relationship to the superior mesenteric and portal veins and the superior mesenteric artery as they pass posterior to the body of the pancreas in the root and mesentery. I'm going to start off discussing surgery for small intestinal neuroendocrine tumors. Now, it's important to mention that even when we think that there is localized disease, nearly half of these patients have lymph node metastasis, even when the tumors are very small, smaller than a centimeter. So we should presume that all of these patients, for the purposes of surgical planning, have lymph node metastasis and need a lymphadenectomy. So they require radical surgical resection with adequate lymphadenectomy, irrespective of what the imaging suggests preoperatively. This is best done in high volume centers. And I think that's really due to the technical complexity of one, performing a selective lymphadenectomy, and I'll touch on that in a moment, but also being able to resect those lymph node metastases that are quite central, quite close to the root of the mesentery. And so there's evidence to suggest that the mortality follows that, and that the mortality is higher in low volume versus high volume centers. This is an analysis from 2018, but this is present in the ENET guidelines of 2024. This was an analysis of 11,000 patients, but really the guideline is that you need to retrieve at least 8 lymph nodes in your lymphadenectomy, and that's independently associated with survival. So we know that a lot of patients are going to have lymph node metastasis, and the key is really what used to happen is that you would do this pizza slice type resection where you would resect an area of small bowel and you take this pizza slice corresponding area of the small bowel mesentery as far down as you could to the base of the mesentery. But actually, what the current guidelines suggest is that you do the selective vessel-sparing retrograde lymphadenectomy, where you can go well beyond this sort of pizza slice area distribution. And then by doing that, you are able to retrieve more of the lymph nodes. So what about surgery for locally advanced or metastatic small bowel neuroendocrine tumors? Well, radical versus palliative resection. So an obstructive small bowel lesion is always an indication for a resection. And often when you have locally advanced disease, as I mentioned, referral to a specialist center will allow for up to 80% of these to be resected, even with locally advanced disease in the small bowel mesentery. The recurrence rates are up to 42% after curative resection, and liver is the most primary site of recurrence. As I mentioned, 40 to 45% recorded in large series. Grade 3 or neuroendocrine carcinomas, depending on which nomenclature you use, are excluded because of the risk of recurrence for a single grade 1 to 2 liver metastasis. Surgical resection is associated with a survival benefit, whereas that is much less pronounced for the neuroendocrine carcinomas. For multiple or bilobal liver metastasis, there is still an indication for surgery provided that there is resectability, although a two-step approach may be proposed. So that may be two-step surgery where you clear one lobe of the liver. You may or may not ligate the portal vein intraoperatively, and then you come back and do a larger resection on the other side. Or preoperatively, you do a portal vein embolization so that you're able to do a, for instance, right hemihepatectomy. The role of primary resection in the presence of unresectable liver metastasis is not clearly defined, but there is a publication from 2 years ago from the SEER Medicare database in the States, sorry, in 2021, that did suggest some benefit, although this is relatively preliminary data and is not part of any guidelines as of yet. And the median overall survival of metastatic small bowel mets is 103 months. So these are the ENET guidelines that we follow. For localized disease, if a patient is fit for surgery, they should have surgery. The surgery should include lymphadenectomy of at least 8 lymph nodes. And if the lesion is less than 20 centimeters to the ileocecal valve, then you must do a right hemicolectomy to get clearance and to perform an adequate lymphadenectomy as well. And then if you have a resectionable disease, you don't need any adjuvant therapy. For patients with metastatic disease and low either liver metastases that are resectable or low burden intraperitoneal disease, you may be able to do complete resectional surgery in one go. Or for complex patterns or intra-abdominal metastasis, you may need to do this sequentially. As I mentioned, for liver resection, you may also use other modalities such as radiofrequency ablation, or you may use modalities to increase the volume of liver remnants so you can perform more radical liver surgery such as ALPS or sequential major liver resection following portal vein embolization. This is an example of just what it looks like. This is a patient of mine that I operated on, I think, about 5 years ago. This is the typical imaging characteristics of a mesenteric lymph node deposit. This is the typical secretizing appearance of a primary. And this is what, on the bottom left, what the lymph node metastatic deposit looks like in the mesentery, often with bowel sort of tucked in there, or sometimes even other parts of the mesentery involved. This is another example of a patient I think I operated on in 2017 to start off with. She's a 67-year-old female who was very well, presented with abdominal pain, diarrhea, flushing. She had a small bowel primary. So she had a segmental ileal resection, lymphadenectomy. She also had a left oophorectomy that was not involved with a neuroendocrine tumor. But she was found to have postoperative liver disease. So she had a stable right-sided liver lesion for which she had lanreotide for a period of time. And we often do this because, as you saw in the previous presentation, the imaging that we do have often underreport the disease burden, and we very often see small volume disease, but lots of it scattered all over the liver. So we wanted to ensure that this small volume disease that we saw in this patient did not represent a small picture of a much wider disease burden. And so she was placed on lanreotide for a period of time. We saw that they were stable, and then she went on to have a right hemihepatectomy in August 2019. She actually had a solitary occurrence as you can see here on the bottom picture, in October 2021, that was treated with radiofrequency ablation. So surgery for metastatic small intestinal neuroendocrine tumors. There are numerous retrospective studies that have demonstrated improved survival and symptomatic control with resection of nodal and hepatic metastasis. So this is really the standard of care. There is a high recurrence rate, and there is an emphasis then often from cure to debulking. And what used to be the norm was that patients were selected on the basis of achieving 90% cytoreduction. That's changed a little bit now. When that was the criteria, there were only less than 25% that were eligible. But there didn't appear, some such studies subsequent to this have shown that there's no apparent survival benefit between R0 and R1, R2 with a debulking threshold of 70% of hepatic disease. So that's associated with a 90% 5-year disease-free survival, disease-specific survival, sorry. And so that is what we try to aim for now. What we try to do is parenchyma sparing debulking when we apply the threshold of 70%, so that we can increase the eligibility, and that's got associated median 3.2 years progression-free survival. There are some contraindications to debulking, such as more than 50% of liver replacement. It's not a hard limit, but very high burdens of liver disease make it very difficult to debulk. Numerous small metastases, poor performance states, obviously liver dysfunction precludes any surgery, or high-grade disease as well. Here is another patient of mine. It's a 46-year-old female who presented with a small bowel NET in 2017, underwent SERT for the liver disease in December 2017, and developed carcinoid heart disease and underwent pulmonary tricuspid valve replacements in July 2019. Very symptomatic with carcinoid syndrome. And as you can see here, very high, very great burden of disease inside the liver. She was actually symptomatic from the small bowel. It was causing partial obstruction, so she underwent a right hemicolectomy in January 2020. It was found to be a grade 2 neuroendocrine tumor of the distal ileum. And then she underwent debulking liver surgery October 2020, where I did a combination of resection of radiofrequency ablation, also reversed the stoma that she had following the right hemicolectomy. And she had quite good symptomatic resolve from that. She was placed on somatostatin analogs. She progressed and went on to have PRT. But as you can see, she's been going for several years, but hopefully the debulking surgery has helped her with her prognosis as well. So I'm going to move on to surgery for pancreatic neuroendocrine tumors. So the incidence has increased significantly, and I would say that it's largely because of the increased incidental diagnosis from imaging. Most are sporadic, but there are some inherited syndromes. Surgical resection is first-line treatment for all eligible patients. For pancreatic neuroendocrine tumors that are greater than 2 centimeters in size, we should routinely perform a lymphadenectomy, and that does mean that rather than doing an enucleation or segmental resection, you have to do a formal pancreatectomy, whether that be a Whipple's or a distal pancreatectomy. But you can consider conservative management for asymptomatic non-functioning PNETs that are less than 2 centimeters in patients that are affected by MEN1, and also selected other patients. That was the guidance from the ENETs in 2017. We have some updated guidance, which I'm going to go on to, but the real issue that we have is that we don't really have high-level evidence of the outcome of these patients. What we always consider is the sort of the malignant type phenotypes, and that is when there's main pancreatic duct involvement or other signs of local invasiveness, jaundice, vascular nodal involvement, etc. So the indications for parenchyma sparing pancreatic resections should really be limited to insulinomas or very small PNETs when conservative management is contraindicated. So in those cases, you can perform an enucleation or a central pancreatectomy for lesions between 2 and 3 centimeters. But the updated guidance from 2023 say that you should be carefully considering this in relation to the patient's comorbidities. and obviously the risk associated with an anatomical pancreatic resection, the morbidity associated with the Whipple's or distal pancreatectomy can often be a number of factors higher. So we do have multiple studies that have reported on outcomes of surgery versus observation for those non-functioning PNETs that are less than 2 centimeters. They're nearly all retrospective, and the selection criteria is often a little bit unclearly defined. But we do now have the interim report from the Aspen trial, which was published in 2022, and that followed 406 patients treated conservatively with PNETs less than 2 centimeters, and none of those patients developed metastasis at a follow-up of 25 months. So that seems to be reassuring that we can treat these patients in that way. And there's similar meta-analysis of observational data that support that thesis. This study is interesting because it was the first prospective study evaluating the efficacy of somatostatin analogs for the treatment of PNETs less than 2 centimeters. In this case, it was in MEN type 1, and with some good results in halting disease progression. So that can be considered in this small patient group as well. So this is the sort of algorithm that I've just described. There is a degree of judgment that you have to apply on an individual patient basis, particularly for young patients between 1 and 2 centimeters in size. And you should always obviously take into consideration the morbidity of the operation that you're proposing versus the patient factors, comorbidities, age, and also their wishes, of course. So these are the ESMO guidelines, which more or less support what I've just been mentioning. There are some interesting aspects here where if the primary is resected, then highly selected cases, you may be able to consider liver transplantation. We have one of those patients on follow-up in my clinic who had a liver transplant in, I think, 5-6 years ago, and who's still not got any evidence of recurrence and obviously doing very well. There are some emerging interesting strategies. This is a relatively recent paper from last year looking at neoadjuvant lutetium dotatate, so PRT, for non-functioning pancreatic neuroendocrine tumors. And in this trial, in this multi-center phase 2 trial, they showed that you certainly did not get a progression, and there is a likelihood that you can downstage disease by using these approaches on a neoadjuvant basis. So surgery for metastatic pancreatic neuroendocrine tumors, you get liver metastasis most commonly. The 5-year survival is about 30% if left untreated versus 60 to 80 if complete resections achieved. And there is a role for surgery for metastatic liver disease. And there is, if you're able to clear all disease, survival benefit, but if you have high degree of liver disease burden, then you may also get some symptomatic control if that is an issue. So in summary, there are clear comparative survival benefits present in the literature in relation to localized small bowel neuroendocrine tumors and pancreatic neuroendocrine tumors above 2 centimeters, and surgery still remains the only curative treatment option. There is a debate for the role of surgery versus observation in non-functioning pancreatic neuroendocrine tumors that are less than 2 centimeters. Ideally, we need randomized controlled trials. That is obviously a challenge. We do have the full Aspen trial reporting hopefully soon. That will give us a little bit further clarity. Overall, there's a lack of prospective randomized data to define the role of surgical treatment of metastatic disease, but retrospective data suggests that debulking surgery may have some benefit, and the role of neoadjuvant treatments is yet to be defined, but there are some interesting data emerging around the role of PRT. Thank you very much for your attention.
Thank you ever so much, Mr. Sodergren, for a fantastic overview of the various surgical approaches and the available evidence behind them. So our final speaker is Professor Rohini Sharma, and I am most grateful to Rohini for talking to us about the oncological management of metastatic neuroendocrine tumors. Professor Sharma, over to you.
Thank you very much, Amira, for the invitation to speak to all of you today. So I'm going to be essentially going through the ESMO practice guidelines, really highlighting each of the individual types of treatment and talking about the evidence behind how we use these treatments, and hopefully giving you a little bit of a flavor about how we can also sequence the treatments. It may be confusing, and it's even confusing for someone that does this all the time, and you'll see the reasons why as we go through the evidence base. So I'm going to start off by talking about the somatostatin analogues, followed by the biologics, peptide receptor radiotherapy, chemotherapy, and I'll touch very briefly on future combinations. So just to go back to what Dr. Wernig was talking about, these key factors really do play a role in what treatments we pick. So you need to think about the tumor grade. Is it a high-grade tumor, a low-grade tumor? And also, more importantly, what is the pace of the disease? If the tumor is a very slow-growing cancer, you might pick a drug that looks at controlling the disease rather than something that wants to try and shrink the tumor down. So chemotherapy versus somatostatin analog. So the pace is really important. The stage of the disease is really important. And you heard from Michael that if you've got low volume disease, or if there's a single lesion, that can be resection, as opposed to a metastatic disease where we're really considering about systemic therapy. And the other key consideration is tumor functionality, which is also being talked about, because that also plays a role in what sort of agents we should use for our patients. So just very broadly, and like I said, I will go through this in more detail. When we're thinking about using a somatostatin analog, we would use this in patients who have functional tumors, low volume disease, grade 1 and a subset of grade 2 tumors, patients who have non-progressive disease. That's really important. And the whole aim of the treatment of using somatostatin analogs is really to delay the time to disease progression. So it's not going to shrink the tumor down, but it's going to delay the time that it takes for these cancers to progress. When we're thinking about targeted therapies, those patients I would consider someone with low to moderate volume disease, grade 1 or grade 2 tumors, and your aim is to try and delay the disease of progression. So these are patients who already have disease progression, and what we're trying to do now is to slow that progressive volume. When it comes to chemotherapy, you might select these for patients who have very bulky, high volume disease, who have got rapidly progression. And the reason you want to pick this is you want response to treatment. So this is very broadly why you might choose these different agents. And I think this is really good to just keep in the back of your mind, particularly when you're looking at the ESMO treatment guidelines. So these are the ESMO treatment guidelines. And what you can see here is they've got small bowel NETs on this side, the pancreatic neuroendocrine tumors in the middle, and then the high-grade NETs at the end. And we're not going to talk about high-grade NETs today. So in the slides moving forward, I've deleted that section. So we're going to focus on small bowel and the pancreatic neuroendocrine tumors. And you can see here already, it's telling us that we should be thinking about grade, somatostatin positivity, and the growth of the cancer when actually looking and choosing the different treatment agents. But you can very clearly see that for some patients, so if you look here, the grade 2 PNETs, there's a whole bunch of things they're suggesting. So how do we as clinicians work out which agents we should use? So let's talk about the somatostatin analogs to start off with. And I'm not talking about this for the management of functional symptoms. I'm now talking about it as a disease to control the disease proliferation. So it's been known for a long time that somatostatin analogs have an anti-proliferative effect. And this is both because it binds the somatostatin receptor, inhibiting proliferation, and also it has systemic effects. So it has like I said, direct anti-proliferative effect and an indirect anti-proliferative effect where it inhibits the cell cycle, inhibits growth factors, it promotes apoptosis, inhibits angiogenesis, and there's also thought to be some immune regulation as well, all of which we see when we use these drugs in our patients. So what is the evidence for somatostatin analogs in the metastatic setting? There's two key trials. The first trial was published in 2010 by Rinke, and in this study, the PROMID study, they randomized patients with mid-gut tumors to either octreotide or placebo. Only 90 patients were randomized, and the trial was actually stopped early because it took so long to recruit through the study. The response rate was very low in both arms. So it's only 2% of patients actually responded to the drug. But the progression-free survival was 14 months with octreotide versus 6 months with placebo. And what was really important was that progression-free survival benefit was really observed in patients who had low volume hepatic disease. And you can see that from the subgroup analysis here is we have the liver involvement. And you can see that when we look at the patients who had less than 10% of liver involvement, the hazard ratio was 0.17. So the maximum benefit was really in those patients who had very low liver volume involved. And when you even got above 10%, your benefit actually reduced down. You can see here that confidence intervals are crossing 1. So the PROMID study tells us that we should think about using octreotide in those patients who have low volume disease from mid-gut tumors. So what about pancreatic neuroendocrine tumors? This was looked at in the CLARINET study. The CLARINET study enrolled patients with pancreatic NETs, GI NETs, as well as unknown primaries. All patients, again, had grade 1 to grade 2, Chi-67 less than 10%. It was a double-blinded study where patients received either lanreotide 120 or placebo. And what you can see from the progression-free survival curves is that with the lanreotide, the median progression-free survival wasn't reached, but with placebo, the median progression-free survival was 18 months. So it came with a hazard ratio of 0.47 in favor of using lanreotide. Again, when we look at the plots, though, it had, again, more benefit for patients that had less hepatic disease. So again, you could use the somatostatin analogs, either octreotide or lanreotide, for patients with low volume disease that have grade 1 or grade 2 in patients who haven't got progressive disease. And that's where that really fits in. And this is regardless of whether or not they're functional tumors or not. In terms of which one would you use, lanreotide versus octreotide, I think there's evidence for both based on these studies. The main issue is that lanreotide is felt to be better tolerated by patients as it's subcutaneous, while octreotide is an intramuscular injection. There is an oral somatostatin analog, but that is currently still in development. We don't have the trial for that as yet. So you can see here from what I was saying, the somatostatin analogs will fit into the grade 1, grade 2, where there's slow or stable disease, and that's where they fit in the ESMO treatment guidelines. So what about the biologics? Well, there's two main biologics, and again, these have been around for a very long time. Everolimus and sunitinib. What are they? So everolimus is a tyrosine kinase inhibitor, and this is it's used in kidney cancer, and that's why I've got this image here. But you can see that sunitinib is here, and it inhibits the VEGF and PDGFR pathway. So essentially, it inhibits angiogenesis. And we know that angiogenesis is really important in the growth of neuroendocrine tumors. Everolimus, on the other hand, is an mTOR inhibitor, and that binds here, where you can see, and it stops, again, the proliferation of tumor cells. Okay, so we've got a tyrosine kinase inhibitor, which inhibits angiogenesis, and everolimus, as like I said, is an mTOR inhibitor, and it's anti-proliferative. What is the evidence for these two studies? Well, both studies were published in exactly the same issue of New England Journal back in 2011. Both studies, and I'll go through each one individually, but essentially they both enrolled well-differentiated pancreatic neuroendocrine tumors. Patients for the sunitinib study had to have progressed within the past 12 months, and most of them were all treated prior, had all received prior treatment with somatostatin analogs. They were then randomized to receive either sunitinib or placebo. There was crossover from the placebo arm into the sunitinib arm on disease progression. And at trial closure, patients could continue on open label with sunitinib. The primary endpoint was progression-free survival. And these are the progression-free survival curves. So what you've got here is across the bottom, you've got time, proportion of patients are on the vertical axis, and the orange line is sunitinib, and the gray line is placebo. So the median progression-free survival with sunitinib was 11 months, which was significantly longer than placebo, which was only 5 months, and it gave a hazard ratio of 0.42. So based on this study, sunitinib is now registered for the management of progressive pancreatic neuroendocrine tumors. What about everolimus? So the trial, like I said, was published in the same issue of New England Journal, and this was the RADIANT-3 study. This was a phase 3 study, patients with advanced pancreatic neuroendocrine tumor, and they all, again, had to have had previous treatment with an agent. So they all had progressive disease. They were randomized to either receive everolimus plus best supportive care, or placebo at best supportive care. Like the other trial, there was crossover on disease progression, and the primary endpoint, just like the sunitinib study, was progression-free survival. And what we can see here is the curves. Again, you've got the top curve is everolimus with a progression-free survival of 11 months, and placebo had a progression-free survival of 4.6 months. So again, everolimus was superior to placebo, and this has then allowed the drug to be registered for progressive pancreatic neuroendocrine tumors. Everolimus was then tested in the RADIANT-4 study, where patients were then enrolled who had advanced gastrointestinal and lung neuroendocrine tumors. So if you recall, the last two studies, RADIANT-3 and the sunitinib study, only included pancreatic NETs. This included GI and lung NETs. They were randomized in a 2-to-1 fashion to receive either everolimus or placebo. And again, the primary outcome was progression-free survival. You can see from the curves that the blue line, which was everolimus, the median survival was 11 months, while placebo, the median survival was only 3.9 months. And so based on this study, everolimus has now been approved for the management of both lung and small bowel NETs. So how do you choose Sutent versus everolimus? Essentially, they have very similar progression-free survival benefits compared to placebo. There's never going to be a trial comparing both of these. And so there's no head-to-head comparison. And I think the best way of trying to decide which agent you want to use would probably be based mainly on the side effect profile. These are the main side effects, the grade 3-4 side effects for sunitinib and for everolimus. And I think one of the key things that really shines for me is the rate of hypertension. So sunitinib is associated with a much higher rate of hypertension. So if you have a patient who is already struggling with this, I probably wouldn't treat them with sunitinib. Everolimus, on the other hand, is associated with hyperglycemia. So again, that might be a factor that you might want to consider when thinking about which agent you might want to use. Otherwise, I feel that the other toxicities are fairly well balanced between both agents. So now if we go back to our ESMO treatment guidelines, you can see I've marked in the pink boxes where you can see everolimus. So as I said, everolimus has been, there was a trial, like I said, RADIANT-4 for small bowel NETs, and that's why you don't see sunitinib in this side of the diagram, while sunitinib was trialed in pancreatic NETs, and that's why it's in this side of the diagram. And that's why I was saying, I think when you're thinking about which agent to pick, for example, for your grade 2 NET, you might think about which one should I choose. I think it comes down to the side effect profile and the comorbidities that your patient has. The next big thing I'm going to talk about is peptide receptor radiotherapy, or Lutathera. So just, I'm sure that Mitesh has already touched on this, but I'll just go through this again. So a theranostic combines both a diagnostic and a therapy to produce an outcome, and that's what's called a theranostic. So you use the ligand both to diagnose and to treat. And I'll give you an example. And basically, neuroendocrine tumors is the hallmark of theranostics. So I think, as Dr. Wernig has already spoken about, neuroendocrine tumors have somatostatin receptors on their surface. And we talked about it before, the somatostatin analogs that I mentioned at the start, they bind with very high affinity to these receptors. Now you can actually stick some radiation onto those somatostatin analogs and visualize where the receptors are in the body. And what I've just shown here is a diagram of the somatostatin, essentially, with gallium, which is a type of radiation that's been stuck onto it. This is then injected into the patient, and you can visualize then where the somatostatin receptors are on the surface of the cancer cell. Now, when you're visualizing where the receptors are, you use a very short-acting radiation treatment. So the radiation's literally in the body just for a matter of minutes to hours. You see that they've got the receptor. What we can then do is, instead of using a short-acting radiation, we can use a longer-acting radiation, such as lutetium. And then what happens is that entire compound of lutetium stuck to the somatostatin analog binds to the receptor. It's then taken into the cancer cell, where it then causes cell death. So essentially, you're now creating a model where you're delivering a very high dose of targeted radiation directly to the cancer cell. So this is a picture of a patient who has had a gallium dotatate scan, which I'm sure Dr. Naik is already showing you. So all the bright spots are essentially where all the cancer is. This is the PET-CT scan, and this is the uptake scan. So on the uptake scan, it's all the black lesions, which are cancer deposits. And on the PET-CT, you can see it's the bright spots, which are the cancer deposits. So this person has the receptor, and they are therefore suitable to therefore have peptide receptor radiotherapy. And the efficacy of this was shown in the hallmark, the trial, the NET-1 trial, which is probably one of the, it was one of the most exciting trials, I think, to come out in neuroendocrine tumors. And this was a phase 3 trial of lutetium dotatate. So lutetium is that long-acting radiation that I spoke about, while dotatate is that somatostatin analog that sticks to the cancer itself. And this was tested in mid-gut tumors. So these again were patients who had metastatic advanced disease. The trial only enrolled patients who had mid-gut grade 1 and grade 2 tumors. They were randomized to receive lutetium dotatate every 2 months for 4 treatments, plus octreotide every month, or octreotide by itself. And the primary endpoint was progression-free survival. This is the progression-free survival curve, and you can see at 20 months, the progression-free survival with lutetium dotatate was 65% versus only 10% with octreotide. The response rate wasn't great. So I think that's something that's really important to think about. The response rate with lutetium dotatate was 10% versus 3% with the somatostatin analog. And these are the long-term survival benefits. So this is now we're looking, that was published in 2011, so it's a 10-year follow-up. So what I think is really interesting about the 10-year follow-up is that the survival benefit isn't there. So whilst it was good in terms of progression-free survival, it didn't change the overall survival long-term in patients that were treated with lutetium dotatate. And then when they looked at the subgroup analysis on the long-term survival uptake, it looks like the benefit for lutetium is again in those patients that have smaller volume disease, so not extensive disease. And I won't get into the reasons for that, but it is because of the depth of penetration of the radiation itself. I think what's really important is that the NET-1 trial looked at health-related quality of life endpoints. And what's really key is what you can see on the blue line, which is lutetium, and the red line is octreotide, is that the time to quality of life deterioration was significantly longer with lutetium dotatate. And I think that's actually really important. We find that a lot with our patients, that they may come very unwell from their symptoms from their neuroendocrine tumor. And then after having lutetium, they're going back to work again, they're able to engage in society. So actually that's one of the things I've found is that whilst you're not seeing shrinkage of the tumor so much, actually their quality of life is markedly improved with lutetium dotatate. And these are a few cases. This is a patient that we treated in Imperial, a 50-year-old woman who had metastatic carcinoid to the bone and liver. On the left-hand side, we've got the pre-treatment, and you can see all the black spots are the cancer deposits, and the bright spots are the cancer deposits on the PET-CT. And then the blue is just indicating the lesions. And you can see there's been a dramatic change after the treatment. Then there's the osseous lesions here, both in the liver as well as osseous lesions. Again, this is another patient, a 25-year-old man with a functional pancreatic insulinoma, extensive disease both above and below the diaphragm. And you can see on the left-hand side, the pre-therapy scan really illustrating the bulk of disease. The middle image is after 2 cycles of treatment, and the last image is after 4. So you can see a dramatic change with lutetium dotatate. And similarly, this is another patient who also has a grade 2 pancreatic NET, who'd progressed with systemic therapy, who had lutetium. And again, you can see on the left and the right side on the end panels, a dramatic change in the bulk of disease with lutetium. What are the adverse events with lutetium? So it's actually very well tolerated. The main side effects are nausea and vomiting, transient myelosuppression, renal impairment, and there is a 2% risk of developing myelodysplasia. And this is the way we administer the drug. So we usually give an antiemetic beforehand to prevent the nausea and vomiting. We infuse amino acids during the entire infusion, again, to stop any renal impairment, and then we give the lutetium dotatate at the same time. So the new study that's just been published is a NET2 study, because the last study I showed you, NET1, was only in grade well-differentiated mid-gut tumors. So the study was repeated again now in well-differentiated grade 2, grade 3 GEP-NET, so gastrointestinal pancreatic neuroendocrine tumors. Very similar study, lutetium dotatate plus octreotide. Actually, it's pretty much exactly the same. The only difference being grade 2 patients were included, as well as well-differentiated grade 3. And again, very similar changes in the progression-free survival. This is the lutetium dotatate, progression-free survival of 22 months versus the control octreotide, which had a progression-free survival of only 9 months. What's important, though, is patient selection. We currently, apart from doing a dotatate scan, we don't know who is going to benefit from lutetium and who isn't. And I think that's really important, given I showed you that there isn't actually an overall survival benefit. So there was a publication by Chan a few years ago where they suggested doing both gallium dotatate as well as an FDG PET to really see which patients would benefit or not. And what they showed is these patients who are on the left-hand side, the patients that just have gallium positive disease and FDG negative disease, have a much better outcome to lutetium dotatate compared to patients who are on this far end where they've got gallium negative disease but FDG positive disease. So it's an interesting concept. I think the plan is for them to look at this further, but I know a lot of centers now will do both a gallium PET and an FDG PET to try and decide which patients they should or shouldn't treat with lutetium dotatate. So this is where PRRT then sits in terms of the ESMO treatment guidelines. So finally, I'm going to talk about chemotherapy. Chemotherapy is a bit of a dog's breakfast. We generally know that it's effective in patients whose cancer has a high Ki-67, so more than 10%. There are a whole plethora of agents which are effective. So cisplatin, etoposide, 5-FU, streptozotocin, dacarbazine, doxorubicin, they're all effective in managing these tumors. Patients who have high-grade neuroendocrine tumors, the standard is cisplatin etoposide, and the response rates are between 40 to 60% with a progression-free survival of 6 months. So are there any trials? Well, There are a number of trials, and this is in patients who advanced pancreatic NETs. And you can see that there's been a whole host of prospective studies, but only in very small numbers of patients. I think that's actually a really key point. And the other key thing to say is a lot of these studies were done before RECIST was actually used routinely. So the response rates are variable and should be taken with a pinch of salt. But you've got response rates, like I said, between 40 and 60% when it comes to the management of pancreatic neuroendocrine tumors. And again, the overall survival is also quite variable as well. I think the key study, which was done in 1992 by Mortel, was a study of streptozocin doxorubicin plus streptozocin 5-FU in well-differentiated PNETs. What they found was that streptozocin doxorubicin had a response rate of 70%, while strep 5-FU had a response rate of 45%. And the time to disease progression, which you can see on the curves on the right-hand side, was 20 months versus 7 months. The ESMO guidelines currently recommend streptozocin-based regimens for pancreatic neuroendocrine tumors where there is bulky disease. And I think that's a really key point. This was all well differentiated. So these weren't patients who had rapidly progressive grade 3 disease. It's well differentiated PNETs with bulky disease. And so that's where it fits currently. One of the other regimens that you'll see a lot used is temozolomide plus capecitabine. And it's used across the entire ESMO treatment guidelines. There's been only very few prospective studies actually looking at this combination. And you can see from this meta-analysis that was done in 2018, the majority of studies are actually retrospective. And in very small numbers of patients, I think the largest study is only 65 patients. But what was interesting from the meta-analysis is that the disease control rate is in the order of 70%. And so TEM-CAP or CAP-TEM, however you wish to call it, has crept into the guidelines and into routine everyday practice. I think the other reason why clinicians like using that combination is because it's very well tolerated. You can see here, the main side effect is really thrombocytopenia that occurs in 3% of patients. So it's a very well tolerated regime that has a high disease control rate. And so again, like I've mentioned, you've got TEM-CAP that comes in, streptozocin 5-FU with the PNETs, and it comes into like every part of the ESMO treatment guidelines. I won't spend too much time on this because I know I've got a lot to talk about, but I just wanted to mention sequencing because that's one question I get asked a lot. Which one should I do and when? And the guidelines are actually pretty unclear because you've got them listed down like as all different treatment options. We don't know is the answer. I think what's clear is that somatostatin analogs should be used first line, and then what comes next, we don't know. In an effort to try and answer this question was the Cabinet study, which was only published last year. And in this particular trial, all patients had to be pre-treated. So they all received treatment with either lutetium dotatate, everolimus, or CAP-TEM. And they were randomized in a 2-to-1 ratio to receive either capecitabine or placebo. And you can see that in the patients that were extrapulmonary, so these patients are the gastrointestinal and pancreatic neuroendocrine tumors, that there was a benefit with capecitabine compared to placebo, and the hazard ratio was 0.38. So effectively, you can say that in patients who have progressed on these agents, you could use capecitabine. And that was also true of the lung neuroendocrine, which we're not talking about today. And everyone will probably want to know about immunotherapy. Currently, there is no evidence for immunotherapy for the management of these tumor types. I think what's really interesting is the DLL3 receptor. And we know that there are quite a number of trials now looking at this T-cell engager compound, which is now coming into clinical trial. And you can see here, there's actually quite a lot of trials that are running targeting DLL3. But this again is mainly patients who have a higher grade tumor type. And this was in the phase 1 study where they did enroll some patients with large cell neuroendocrine tumors. And again, you can see that there's a reduction in the size of the tumors. But apart from this, there's currently really no evidence for using immunotherapy in this tumor type, and in particularly for the grade 1, grade 2. So I will finish there, and thank you very much for inviting me to speak today.
Thank you so much, Professor Sharma. That was absolutely wonderful. Can I just clarify very quickly that in your last couple of slides about the future directions, did you mean cabozantinib? Because you said capecitabine. Did you
Sorry,
mean...
sorry, it's cabozantinib. Apologies. Yeah.
Thank you very much indeed. So it is 5 p.m. UK time, and I think 6 p.m. 8 p.m. in Abu Dhabi. Thank you so much for staying with us. I'm now going to share the QR code for your CME or CPD from Department of Health or the Royal College of Physicians. What you need to do is to scan this and very quickly fill in your feedback form. Let us know how you found these lectures, and then please take care when you're typing your name, because that's what will appear on your certificates.